now we come to often the best part of the day. I meant to say that this morning and I forgot. But it's really exciting because it's an opportunity for you to ask what you would like of early to mid-career researchers. So not people that are old professors, but young, vital people whose careers are just heading off in that very steep trajectory. So I'm very grateful to you all for coming along. And we've asked, oops, I think I've just lost, can you hear me? Yes. We've asked people from different backgrounds so that you can get different ideas about how you can make your career work. The aim of this session is that you ask the questions. So what we're going to do is I'm going to introduce our team of panellists, and then they're going to tell you a little bit about their own career journey for about 5 minutes each, and then it'll be open to you for questions, and you can ask them anything that you've thought about that might be of interest. So I'm going to take this in the order on my piece of paper, which isn't the order of the people in the room. So Ada, just give us a wave here. Associate Professor Ada Cheung is an endocrinologist who works in an incredibly important and topical area. I probably shouldn't say it that way, but it's true. She's a counsellor of the Endocrine Society of Australia and a member of the Global Leadership Academy and Committee on Diversity and Inclusion of the US Endocrine Society. Since completing a PhD in 2017, she's established and leads the Trans Health Research Group at the University of Melbourne, which aims to improve the health and well-being of the transgender and gender-diverse community. And she has a large team that undertakes co-created quantitative and qualitative studies in gender-affirming hormone therapy, mental health and well-being, as well as research healthcare delivery, and her research has led to the development of new gender clinics in Victoria, a statewide training program for health professionals, and that is incredibly important. We just had 2 of our 4 monitoring rooms with trans males in the rooms, and our meeting had huge trouble trying to say they and not she or he. So I think it's really an important issue for our medical societies as well. A statewide training program for health professionals and national guidelines on hormone therapy. And her commitment to co-creation to improve trans health was recognised recently with the Globe LGBT Ally of the Year. So a fascinating field. Next on my list is Dr. Annie Chiu, who's going to wave. That's Annie. And Annie works with me, and I asked her to come along because she's actually come from Hong Kong to work with me and train. She's right at the end of her paediatric neurology training and is a consultant, and she's come to Australia because we lead the world in our area of research. And this is just to say it's great to go overseas. We didn't hear that much about going overseas today. We've heard a bit, but perhaps not as much as many of us has done. But it's important to recognise that people are coming from overseas to hear. Is this working? Yeah, it seems like it's coming and going a bit. And she's just decided to, she's been with me about 8 months, and she's just decided, thank you, to pursue a PhD. So you can ask Annie about that. Why would she want to stay in Australia, you could ask. Dr. Jessica Green is a consultant psychiatrist at Peninsula Health and is doing a PhD through Deakin at the Food and Mind Centre at Impact. And she has a subspecialisation in psychotherapy, specifically in brief structured therapies such as CBT. And her research is focused on a very trendy area too, gut-brain axis. And she's leading a trial investigating the use of fecal microbiota transplants for major depressive disorder. So all you ever wanted to know, we can ask. And she's passionate about holistic psychiatric care, including psychotherapy, gut-brain axis medicine, and novel evidence-based treatments. And finally, we have our surgeon. So I'm very delighted that Professor Shomik Sengupta is here, who's a urologist at Eastern Health and Monash University Eastern Health Clinical School, and has a practice in uro-oncology, including open, laparoscopic and robotic cancer surgery. He's a major contributor to the US ANZ, having been chair of the Victorian Training Committee for several years and leader of the GU Oncology Advisory Group from 2013 to 2019. And he's been involved in clinical trials in prostate cancer trials and members of scientific boards, and also had leadership roles in a number of conferences. And importantly, Shomik is one of our mentees of our flagship mentorship program, and he has, all of the speakers have very kindly agreed to come along today. So Shomik, do you want to tell people a little bit more about you?
Hello, is that working? Can you hear me? Thank you for the invitation to come along. A surgical academic is a relatively rare find. I got interested in research very early on through my medical school. I spent some of my summers doing sort of summer vacation studentships, and I'm sort of very encouraging of our current students to come along and do that. That really made me understand a little bit about science and engendered a love of science in me. Through my clinical training process, and surgical training is a fairly long process, I took a couple of periods of time off and did a master's initially, which was looking at sort of colorectal carcinogenesis. I was just sort of starting my training journey. I wasn't yet a committed or trained urologist. And then subsequently, after I finished my training, I went overseas and did a kind of combined research and clinical fellowship at the Mayo Clinic, and that involved doing a further period of research, including a little bit of laboratory research, but quite a bit of kind of clinical database-driven research in particularly prostate and kidney cancer. And that formed part of the basis, and then subsequently came back and was involved with various clinical research projects, particularly on uro-oncology, that formed the basis of a MD that I ultimately completed in 2014. So I think by certainly my institution's definitions, I'm still an early career researcher. So I'm relatively, I guess, in mid or senior level in my clinical journey, and relatively early to mid in my research journey. That's been my journey to date, and I guess sort of combining surgical clinical practice, which itself has certain challenges and differences from many other areas of clinical practice, and clinical research, which is one of the more challenging varieties of research, is something that I try to juggle and can try to speak to. Thank you.
Thank you so much, Ingrid, for inviting me to be here today. It's an honour to be speaking here, besides all these amazing and distinguished researchers and professors. So, yeah, I'm a very junior researcher, currently still doing my PhD. It's finally near the end in the area of gut-brain axis medicine. I made the decision to pursue, I suppose, psychiatry, my clinical area, because of my interest in research also, I suppose. That was one of the driving reasons. So I viewed like psychiatry as, perhaps compared to other areas of medicine, there's so much room for improvement, it seemed, and discoveries, and so much happening in the field that it seemed like a really exciting area for research. And so I started doing my PhD in my final year of psychiatry training after having spent, not an indirect route. I had taken some time off and going to conferences and travelling and trying to meet, exploring various research interests and other life interests. And I eventually met my primary supervisor, Professor Felice Jacker, at a conference. She's the founder of nutritional psychiatry, and I was just inspired by her work. And so I guess to anyone who's sort of considering a PhD, this is sort of my story of how I ended up in the area that I did and doing what I'm doing. So I asked Felice if she was taking on students, and she said she was. And Felice emailed me one day asking if I would like to do a PhD in poo transplants, and I said, well, as long as I don't need to touch the poo. So anyway, and hence I found myself doing this amazing and really interesting research. It took 4.5 years between when I enrolled in the PhD but to when we had everything at our disposal to actually begin the clinical trial. Which is now completed and the findings published, which I'm excited to say. Yeah, many barriers to overcome with getting that research done. And yeah, that's probably now just writing out the final findings now. So that brings me to now. So
does the poo work?
Well, after all that, I wish I could say it does, but one of the barriers was the funding. So we had an N of 15 study. That's I was saying the others. This is very expensive research. A fully powered RCT would be something like 160 people because studies in mental health have very strong placebo effects, so you need really high numbers. If a participant, so we had 5 participants who got a placebo and 5 who got active FMT. So if someone in our active treatment arm got COVID during the trial and their mental health symptoms went down from baseline to when we assessed them at the end, well, I guess that goes to show how small sample size, how skewed the data can become. So we found that it's highly feasible, which was a really important finding. Like, it just highlights the unmet needs in mental health. Sorry, I'm going on, but just highlights the unmet need in mental health and how desperate people are to have alternative treatments to what currently exists. And so hopefully our little pilot study has demonstrated that there is a need for more funding and an efficacy study.
Real trials, further trials.
Sorry?
Further trials. It's
exactly.
Ada.
So I fell into this area serendipitously. I had never heard about transgender health in medical school. I'd never heard the word transgender in my endocrine training. I did a PhD in androgen deprivation therapy for prostate cancer, understanding the effects of that. And it took me 6 years after my endocrine training. I had children during that time, and there were enormous barriers during my PhD. There was misogyny, there was racism, there was... I was fighting a lot of battles. And then towards the end of my PhD, I also, struggled with some mental health issues. And I was having lunch with one of my colleagues who told me that he was seeing more and more transgender people but couldn't find anyone willing to see them. And then I thought, well, as a doctor, how can you refuse to see a patient? So I said, I didn't know anything about trans health, but because I was quite fired up from all my fights against all the discrimination, I thought, this sounds ridiculous. I'll see them. So then I just listened to story after story of just discrimination and health equity that I'd never heard in any other population. Suicide, I'd seen, my patients were committing suicide in my clinic. I mean, not in my clinic, but I'd had patients that had died. They were facing discrimination in all levels of society, in accessing housing, getting a GP. Had patients turned away from GPs because they were trans or told to get out because the dermatologist wouldn't see them. People couldn't get jobs and unemployment, the social determinants of health that we heard about today. And also, when it came to hormone therapy, which is the thing that I was working in, there was hardly any research, none whatsoever. We were just making it up, how we were giving hormone therapy. And so the community really struck a chord with me because I felt that it was just so inequitable. And it was just so unfair, and they weren't getting a good go, a fair go. And also that there were so many unanswered research questions, and I had all these clinical skills to not only treat them to improve their mental health, but also conduct clinical trials to answer a lot of the unanswered questions. And so I started a research group, and I finished my PhD in 2017. So it's been a rapid journey in the last 6 years. Got some grants and a PhD student, and we've just grown and grown and grown over the last 6 years. All of our research is now really community-led. So we do research in we do a lot of clinical trials, everything's co-created, and that sort of set us apart from other people. It's still very much taboo, so there's very little people around the world willing to work in the space or undertake research in the space. So we have a bit of a niche and a huge clinical need. That's sort of where I've gotten to today.
I'm at a place I never thought I would be when I started medical school. So it's been a lot of unexpected journeys. Medical school itself was slightly unexpected to begin with, but I really loved kids, so I went into paediatrics, and somehow I went into pediatric neurology and found that I really loved it. And I was originally meaning to, but I wanted to explore epilepsy, so I asked my professor at the time to write a referral for me to come to Ingrid. And I was originally planning to come in 2018, then because of various service needs, it was deferred. And then COVID came, and within COVID, I eventually completed my pediatric neurology training. So by the time I came, I was sort of already a full-fledged pediatric neurologist, and I just found the environment here I love the academic environment here. I find that, people at the Austin has been very focused and very serious about the quality of work they produce. So I really found it attractive, so I'm thinking about doing a PhD here.
Great, thank you very much. So really now I'd like to open the floor. We have Abby and George ready with microphones. So please go ahead. There's someone at the back over there, and there's someone was there a hand up over there too? Yep, please, over on the left.
Oh, hi. I was just hoping to get your advice on how to negotiate authorship early, and also if there are authorship disputes, what you can do practically. So how do you decide who is first, second, third, or last author, and perhaps if you've contributed and you've had an agreement to be on the author list and you've been left off, what can you do in that situation? Thank you.
Well, Shomik, I think you maybe should take that as the professor on the panel.
Authorship is one of those really vexed aspects of research, isn't it? Everyone who ever is involved with it. I mean, it varies a lot. There are some projects where there is often not even a question. I mean, someone has primarily done the research and written the paper, and they should be the primary author. If that's not happening, that's usually a very bad situation that needs to be taken up. But if you've got a supervisor who is kind of protecting your interests, typically speaking, if you as a junior researcher have done the work, you should be the primary author. They'll often be the sort of senior author. If others have contributed, they'll fit in somewhere in the middle. And I think that's relatively undisputed. When there are more complex situations, there are certainly, particularly in clinical research, sometimes there might be data collection or patient recruitment that takes place over a long period of time, and there may be 3, 4, 5 people who might have contributed to doing that, and then ultimately someone else comes in and writes the paper. That's a much more complex situation, and trying to weigh up which of those people should get what level of recognition in the authorship list is a difficult thing to do. In my sort of the principles I use in that is that it's a proportion of how much you've contributed. Whoever has written it will typically often be the primary first author, and they will hopefully have had enough involvement in the rest of the study and the data collection and analysis, etc. But that situation is somewhat more complex, and you can have dual first authors or shared sort of 3 or 4 first authors if they have really been part of it, or otherwise it's a case of someone writes the paper, others are listed in order of contribution in some way, and some acknowledgement is made somewhere in the body text to make sure that's highlighted. And disputes are hard to resolve, and usually you hope that there is someone senior involved in the whole process who will sort of mediate and try and resolve some of those. Hope that answers the question.
I'll let Ada have a go at that as well. Was the other
Okay,
senior?
this is an issue really fond to my heart. When I had my second child, I was 4 years into my PhD, and when I was on maternity leave, my supervisor took my authorship away from me. And so I'm still fighting that battle now. What I've learned from this is that there are universities, and I didn't even know this at the time, has got very clear authorship policies. And authorship should be decided at the beginning of the project, and it should be written down, and it should be disseminated to everyone involved in the project. And so that's how I try to operate now, like be very clear and transparent right at the beginning of my projects. The ICMJE has got the credit taxonomy has got different contributions that each author should be making, and I think it needs to be really clear. And if there's any disputes, most universities have got an Office for Research Ethics and Integrity, and I think you can always call someone for assistance. You can call an Human Research Ethics Committee, or you can call the Office for Research Ethics and Integrity.
Thank you. I think there are a few really important points. One is it should be outlined at the beginning if you can. I would always put a PhD student first if they wrote the paper, but they must write the paper. So just remember that your work is not done if you have not written that paper. It then has 20 drafts, but you need to write it. So it's really important, and I think discussion is important, and a good supervisor, someone who's wise. And the other thing I'll say is generosity of spirit. Always have generosity of spirit. You may not be first author on every paper, but at the end of the day, it's about building relationships, networking. We've heard that all day long. I have friends all over the world, and if I wasn't first author on a paper here or there, it's not the end of the world. So just remember, this is a lifetime, not a paper. And you want those relationships because that's the stuff of life. All right, there's a question over there.
Yeah. Thank you, everyone, for your time. I guess for me, I'm very early trying to look into different research projects and complete and publish. So navigating as many projects and gaining skills is very essential. But can you please reflect on a time where you decided this is going to be my field and this is the field that I'm interested to publish in? Because as a researcher, there's always going to be exciting opportunities. So when was the time when you said, no, this is the time and this is the field I'm going to focus on?
Jessica, I think that's for you.
Well, I guess like I mentioned before, my PhD topic was decided by an email from police. But with respect to my deciding on a topic, and I don't know if this is what you meant, but like being stuck with it for a career, I think that you can have great breadth as in a career of research, and that you can move from topic to topic at any time. I mean, everything's related, and the research skills are quite translatable. And if I have an interest maybe later in transgender health, I would hope that I could do some research in that too. And I am involved in other research projects that aren't in my PhD area of gut-brain axis medicine. So I think that's a wonderful thing about research, is that there are so many possibilities all the time, an overwhelming amount of possibilities. I don't know if that's answered your question at all.
Shomik, would you like to have a go at that one?
Yeah, look, reinforce what Jessica said. It's a matter of keeping your eyes open. I mean, you'll obviously have some interests that will guide it a little bit to look for opportunities. I mean, I'll give you a couple of examples, I guess, from my journey. I mean, during my student placements, you do short bits of work over a few weeks. You'd never really expect it's going to translate into something publishable, but my first ever paper arose out of that. Back then, there wasn't Google and everything else to help you find things, and I didn't find out for about 10 years or so, but I'd done some work and it had been a little figure and was incorporated, and the person was generous enough. I was about 10th author or something in a long list, but because they had used that bit of work that I had done as a summer student, I got put on that. My master's project came about just because there was, one of my supervisors had a student develop a model operating on rats to try and test out putting stuff into their colon, you know, similar to your project in some ways, and they were looking for someone to take that on. And as a prospective urology trainee, I got this opportunity. I was a bit conflicted. Should I go into this kind of general colorectal project? But research is research, and it resulted in about 4 or 5 publications and a master's, and really set me up on my research journey. So just having those opportunities will often crystallise your interest and lead you down a pathway, and it's keeping eyes open and looking at, I guess, the serendipitous connections. You know, you ran into someone and asked them about it, and that led to your project. It's really how a lot of these get set up in the first place.
Yeah, it's serendipity and seizing the day. Now, do we have some more questions? Right in the middle there. Thanks. Sid.
Great, thanks. Thanks so much for coming on the panel and giving up your time. I'm Sid. I'm one of the MD PhDs just finishing up this year. My question is twofold. Firstly, how do you manage your time in terms of wearing your clinician hats and then your academic hats? And secondly, from a junior doctor, junior clinician perspective, what advice do you have to give for anyone who wants to embark on a career as a clinician-scientist? Thank you.
Okay. Annie, do you want to start?
That's a slightly tough question, because I think back in Hong Kong when I started, the environment is slightly different from what it is here. So essentially the balance between being a clinician and a scientist would be you do your day job as a clinician, and after you finish your work, you think about what you want to research on, and then go home and do the research part, and then come back the next day and be a clinician. So that's sort of an easy divide. But I believe here you have a lot more opportunities. Like, for example, this morning with various sorts of programs coming on, and I see colleagues here who do part-times and try to juggle and discuss with them within their own institutions as to how much clinical work you want to do and how much research you want to do. So,
great, thanks. Yeah. Ada?
I think the balance is really hard to find, and it's really individual. Clinical work will always call you first and is sort of always more urgent. And I think if you want to, it's very easy to let clinical work take over, because there's always some sort of urgency, there's always patients. I do 1.5 days clinic, and the rest of my time is research, and I like that balance, but it's different for individual people, I think. I can't remember the second part of your question.
What advice would you give for, I guess, junior doctors or junior clinicians who want to embark on a clinician scientist?
Follow your passion. I think if you're going to, and whatever research you choose, you can change. Like I studied androgen deprivation therapy and prostate cancer for the first 6 years, and I still do a little bit of that. But then, I found that I was able to make more impact in this other space. And so I think just follow your passion, because you're going to be working in this space for a long time, and research is challenging. There's a lot of knocks. There's a lot of picking yourself up off the floor when you put your heart and your soul into the grant and it's rejected. And so I think if you don't love what you do, it's really hard to continue. So just find something that you love and you enjoy and you feel you get reward from.
Do you have a comment about balance?
I don't know that I have that answer, but I think it's about I suppose it probably is specialty dependent, perhaps, if you're in the medical field. But once you finish, there's often a lot of flexibility around, more flexibility than there are in training programs around how you can structure your days. And just to pick up on what Annie says, like sometimes it is that can even involve just doing it in your own time. But it is a difficult problem. There is just so many challenges to call it the work-work balance, balancing your clinical work with your academic work, and then maybe the third work if you have family or kids, the work-work-work balance. And I don't have the answers. I probably don't have the answers yet, but I'll...
And Shomik, it's particularly a different world in surgery.
Yeah, I definitely don't have the answers. Just ask my wife. And surgery poses certain additional difficulties in that we see patients and then operate, and there's a lot of surgery that's less controllable than other spheres of medicine, and there's less things hand-offable. We do cross-cover a little bit, but unlike in other specialties, we can't hand things off quite as easily. And I think the relative barriers in sort of a clinician-scientist process is greater in the surgical world. In the medical world, both in terms of available time, available support services, etc., are better. And I'm using the word medical to refer to sort of physicians, but obviously there's a range of other specialties in medical practice that exist, which I probably don't know as much about, but certainly what I see of sort of medical colleagues and oncologists or renal physicians, they have a different model whereby they can combine clinical practice and research, and sometimes in an integrated whole that works. And what Ada described is something that I'm familiar with, and I think fosters a better interdigitation between clinical work and research, which in the surgical sphere it doesn't exist as universally or as easily, and has to be often created with some effort. And that whole creep of clinical work coming in and sort of taking over every available space and a little bit more is difficult to guard against. So you have to be somewhat deliberate, and you have to, I do about 50% of my work in private, and that's another problem. There is often an economic imperative whereby to run a private practice, you can't do that beyond a certain point in terms of restricting its time. I do some public practice, and again, we have very resource-constrained environments, and if there are things that need doing and you need to do it, and I now have a bit of a leadership position within the unit to try and make sure that the unit is ticking over and so on, you can't let go of that, because then you're falling behind in the waiting list, and that's a perennial problem, etc. And then you've got to fit in your research as well as, not to mention all the sort of administrative and leadership components that you've got to fit in around it. It is sometimes a matter of doing the work in the evenings and on the weekends, and kind of bearing the complaints from the family members saying you're in front of your laptop again. And I haven't built into that. I'm luckily at that phase of life where my kids are grown up, and as a male I've had that privilege that I've been able to do what I wanted to rather than what I had to, and I think those are all additional challenges. And yeah, sometimes you just end up putting in the extra hours, etc., because you want to do it and because you believe in doing it. It is a difficult journey to forge sometimes, which we as a collective need to kind of try and make a bit easier and a bit more planned and programmed.
Thank you. More questions? Can I see? There's Sophie has her hand up.
Can I ask one? Sorry.
Oh, okay. Didn't see you. Thanks.
Yeah, my name is Cheung, and I'm a second-year medical student from Monash. I just had a question about, as a clinician-scientist, from your own experience and what you've seen of the people that you've mentored, is it worthwhile for students like us to go out and get some experience in a clinical setting first before conducting research, or is it okay to just kind of go straight into research and then try and integrate clinical experience into that?
Who would like to take that? Ada? Yes.
I think everything we do research-wise is to improve the health and well-being of communities. And it's you kind of need that clinical perspective to know what's relevant. And so you need to have someone asked me this earlier, you need to have some sort of clinical experience to know what's known, what's the current state of play, and what are the problems, and how can my research answer some of these unanswered questions. So you do need a bit of clinical perspective to guide your research. And then you also talk to patients and you know what's important for them, and that community and consumer engagement as well. So I think you need both, but it's hard to jump in deeply. You can jump in, but you can't jump in deeply without having some clinical exposure. And it's nice to be able to bring that research back to your patients as well.
Any other comments from, Shomik?
I'll make a brief comment. I'm endlessly surprised and amazed by what I see students do in various stages. I think as students, when you enter the clinical phase, if you're learning, I certainly see some very valuable contributions made, but I agree with the principle of what Ada said, that without some clinical reality, clinical research is a difficult thing to do, and particularly from the supervisor's perspective, it needs a lot more guidance and hand-holding because you don't necessarily have that perspective to bring to it. But I think what the students have brought is often a great deal of enthusiasm and a new way of thinking and a freshness which I've found amazing when I've sat in on some of the student presentations. And I think there's no absolute correct or incorrect answers about this. I think when you are interested, when you find opportunities, is the time to get involved with research. And it may be as simple as just helping out with some data extraction in a bigger scale study that's happening, to actually taking time off and doing a BMed Sci that can then progress on to something bigger like a PhD. We've had a student do that and do some really amazing work that has won prizes at conferences, etc. And she's probably been a star kind of research student over the last few years. So there is no one size fits all. I wanted to also make the broader comment, and again going back to particularly the surgical clinician-scientist, is that fitting in research and particularly research degrees or a big research project, you talked about the 4 or 5 year journey, is difficult enough in a clinical training and clinical pathway. It's close to impossible in a surgical pathway because in many other spheres, you can be doing some research and doing 1 or 2 days of work and still be maintaining skills and still be learning, etc. In surgery, that's an extraordinarily difficult thing to do. If you're a surgical trainee, you take time off, you go backwards in terms of your surgical skills, and there is a great deal of difficulty in interdigitating research and training and research and surgical practice. So these are difficult questions at every level of the journey, whether it be at medical student or a kind of trainee or even beyond that during your practice. But, if it was easy, anyone would do it, right?
And we need a lot more surgeon-scientists. I was complaining to Shomik before that we have far too few. I know Sid is just towards the end of a PhD in orthopaedics and med school, so he'll be a budding one, but we need a lot more surgeon-scientists and we need better pathways for them. Because at the moment it's very much physicians, occasional psychiatrists, not enough of them either, and it's so important. Now, Sophie.
Thanks. I'm Sophie. I'm a first-year medical student at Deakin. My question is about, or in regard to the barriers, particularly what you mentioned at the start, Ada. If you have any advice, I guess, on how to manage or tackle some of those barriers, especially for, when you might be more junior in the clinical space.
Yeah. It's, I think it's really challenging when you're junior and you don't necessarily have power or voice, and I have to admit that it's taken me a long time to feel that power and that voice to be able to call out inappropriate behaviour. But I think a lot of the junior staff that I work with are much better at it than some of the more senior staff at calling out inappropriate behaviour. And so I think just trying to find your voice and trying to find calling things out when you feel that they're incorrect and they could be potentially done a better way. Thanks.
Other comments around that?
The only comment I'd make, I agree. Obviously, you've got to negotiate your pathway, but it shouldn't fall to you. It's about the establishment changing, and it is, and it's about those who are in those positions of power, and hopefully more and more people are seeing that it needs to be an equitable stage on which everyone has an equal opportunity to also take that action. So hopefully that'll happen. It doesn't always, but hopefully it will.
Thanks.
Thanks. More questions? Oh, yes, over here. Thanks.
Hi, my name is Alice. I'm a first-year medical student from Deakin University. My question is very similar to Sophie's question, but more specifically in surgery. I'm currently passionate about cardiothoracic surgery, which I recognize is a very competitive field. Do you recognize any barrier, especially for female, Asian female, surgery, which is a very competitive medical field? And if so, any suggestions on how we can fight against it?
Shomik.
If I understood your question, you're asking about sort of pursuing a surgical career and what barriers being female or being Asian might pose to that. Look, certainly historically there has been a huge barrier. If you look at the proportions that we have in terms of gender distribution within our medical school, and then compare that to every level, sort of training, representation through to the surgical workforce, and then through to surgical leadership, it becomes a gradually diminishing proportion. It is changing, but slowly. I'm lucky to be part of a subspecialty. Urology has been one of the leading ones, and even within that, I think it's something like only about 25% of our training mix is female, and it's a smaller proportion than that. I don't know the figure off the top of my head who are qualified urologists, but we were the specialty that had the first ever female trainee, Helen O'Connell, back in the early 90s. She's now our first ever female president of the Urological Society. So I, at Box Hill, was working under a clinical director, Caroline Dowling, who was one of, at that stage, along with Helen, two female clinical directors. So in positions of leadership, there are females coming through, and that just represents that there's sort of a gradual change that's happening. Having said that, I think there still exist some barriers. I think now with selection processes, etc., the opportunities are designed to be more equitable, so that if you fulfil, I guess, the various steps that you need to, and you show excellence in the various parameters that are assessed, you will get a chance regardless of what your other background is. But that's kind of the setup. It still doesn't take away from the fact that if you're a female trying to plan a surgical career, the facts of how planning your family, etc., might work out will pose a challenge in how you build that into it. There is a requirement for being able to access flexible and part-time training and interrupted training in order to facilitate those things, and it happens. We've had a part-time training at Box Hill, but they're hard to design and come by. So that poses, just one natural barrier that just is there as a reality of life. So the truth is there will be some, but if you are, again, goes back to passion. If you're passionate about it, if that's what you want to do, and I've seen colleagues and trainees go through the journey and do it and have kids and juggle all of those things in a way that blows my mind. I find it hard enough to juggle all the things that I do, and to do that on top of that is just, hats off. So if you want to do it, just do it, and hopefully the rest of us will try and facilitate it.
Ada?
I think right now, post-COVID, we're seeing a real cultural shift and a cultural change. And I think to battle, a lot of our barriers are systemic misogyny in society, in parliament, in hospitals, in universities, in academia. And I think there needs to be, you asked what can we do, we need a grassroots kind of movement where we share our stories and we have voice and make people recognise that this is an issue. But we also need top-down sort of leadership drive and investment in resources, in diversity and inclusion. I've seen the College of Surgeons actually make a huge amount of change over the last few years to improve that diversity and inclusion. I'm speaking at a urology conference later in the year, and I tried to pull out, and I said, I've got this other person. And they said, no, we have a very strict gender speaker balance. And so things like that, you know, where we make sure that there are female leaders seen on panels, in conferences and in leadership roles in universities, in hospitals. But I think it takes a lot that leadership of our universities and leadership of our hospitals and our medical environments need to recognise that a cultural and climate shift needs to happen and invest in that. And there needs to be solid policies and procedures that we as individuals can't change, but people in leadership positions can. And it is changing, slowly, but it will change.
Shomik.
A comment I was going to make about that, I don't know the very current status, but I remember seeing a post on social media going back probably about 12 or 18 months ago, which listed the leadership of the various medical colleges, College of Physicians, College of Surgeons, etc. And every one of them had either an incumbent or an incoming female leader, which I think was the first time probably in history. And I think that's indicative again of a little bit of that groundswell of change. And it's probably a sort of time-related thing. Like I said, one of the first female urology trainee was in 1990, so they are now, you know, sort of that 25, 30 years into their career, reaching that point where, and Helen as a natural leader has led various aspects of urological practice from her institution to now leading our binational organisation, and that's increasingly, hopefully, going to happen, and that will then translate into that top-down change. And I think it's impossible to get away from the fact that this all exists, but I'm heartened to think and say that it is changing, and where it's existent we need to, you know, collectively call it out, etc., but still, I guess, fan the flames off those changes so that it does become something much more equivalent.
Do you want to add anything, or?
I guess I can't speak to surgical training or specialisation, but I guess just to note, you know, from my own experience, I had 2 kids during my PhD. They're now still quite young, and I think that they're, you know, the gender imbalance does still strongly exist, unfortunately. And there is huge systemic problems in place. I mean, you know, they're just, you know, just at a political level in terms of paid parental leave, and when you're applying for grants and your career progression being noted, these gaps do impact career. And though while grants, you know, some of them have like sort of a nod to career interruption and purport to consider that. I'm not sure how they do, and whether there is at the moment, you know, appropriate measures in place to ensure gender equality. So I think, you know, noticing, you know, many of us, you know, in the room, you know, we have a strong, like, so the medical world at least has a very strong hierarchy, and at the bottom we're made to feel very, I don't know, unimportant and so on. And then as you go up, you can continue within you some of those feelings of powerlessness, though we actually are in a very privileged position in society as medical persons, or as scientists, as researchers, as clinicians. And so, you know, just echoing on what Ada was saying, I think that we have to carry that responsibility to fight for those changes and to use our positions of power, even though it can be scary to do so. But that's how changes will be affected. So, yeah.
Yeah, look, I think that's all incredibly valuable comments. Thank you. I think gender equity is alive and well, sadly, in our society. It's certainly been there all my career, and I still work with a lot of old white men who don't even see it. They have no idea. And you'll point out a program has no female in it or no chair that's female. And they go, oh, yeah, but they really don't see it. I'm not sure if those very old white men will ever see it, but hopefully all the young, hopefully many of them are non-white men here as well, it won't be such an issue. I think it will be part of our normal life, thank goodness. But women, it is very difficult, and you're trying to juggle career with children, and I think it is going to get better, but it's not going to be fast, and I think we have to call it out. But it's also very important. Now, we're going to move topics, I hope. Who's the one with there's someone with a mic there.
Sorry?
Yes,
hi.
please.
Thank you. Because I'm actually an undergraduate student in Melbourne Uni, and it's probably a bit early for me to ask this question, but I do find inspiring in the field of human health and in particularly human nutrition, and I'd like to know from the perspective of professors or doctors or researchers, how closely related or working for nutritionists and doctors, do you think? Or what advice would you give to students who are like pursuing a career in a nutrition pathway? Thank you.
Okay, well, we have lots of nutrition scientists or dietitian scientists in the academy who are fellows, so you can do world-leading research in nutrition. But do others have comments? Any of you work with nutritionists or dietitians?
I guess I do through the Food and Mood Centre. It's if you have interest in doing in mental health and nutrition, they're doing a lot of great research there. I don't know if you had a sort of specific question about a nutrition career and research.
More like how closely nutrition
Abby, we can't hear, thanks.
Like how closely would a nutritionist work with doctors and perhaps researchers?
I think very closely. A lot of us would work with dietitians. I run a clinic with the dietitians once a month on the ketogenic diet for epilepsy. I'm very keen for dietitians to do research, to think about PhDs, but you can't. A little bit of research on the side isn't enough. I hope that's been shown to you today. You've got to go and do a substantial body of research, get a PhD, learn to think differently and better with a PhD. So if you're thinking about that, that would be wonderful. Yeah, please.
Yeah, I can't speak definitively about sort of nutritionist or dietitian. I sort of have passing interactions with them, but do a more general comment about allied health and non-medical people, and I'm part of a clinical trials group, a binational clinical trials group that looks at urogenital cancers, and in all of the projects and all of the studies that we design, we typically have a multidisciplinary team. We have nurses and certainly psychologists and health economic experts involved. And that's vital because, while the intervention might be medical or surgical, the effects are multiple, and therefore to measure those things, we need the help from those people. And related to that, in almost everything we do, we tend to have a very medicalised model of looking after patients. All of us do our little thing of, whether it's operating or drugs or whatever it might be. But when we get that opportunity to work with, in certain areas of my work, physiotherapists play a very important role, and our clinical care is better when it's done in a multidisciplinary team. So the sort of short summary of that long-winded response is that I think both in clinical practice and in research there are important collaborations and links between medical and non-medical allied health fields. They don't always exist, but again, that's probably an opportunity to kind of create them and to do some research in there. And I think, there's lots of opportunities. That's a short answer.
Yeah, multidisciplinary care is normal these days and the way to go. Was there a question here? Oh, yeah, thanks, over there. Please.
Oh, hi. I've heard many academics say that the hardest part of a research career is securing grant funding, and it's not uncommon to see many outstanding researchers repeatedly apply for grant funding and repeatedly get rejected. So how do you write a stellar grant funding application, and what's your practical advice on how to secure research funding?
Ada?
start small. So I think there's a lot of like small research grants that hospital foundations or philanthropic foundations or university might provide. It's certainly like the bigger grants, like the NHMRC grants, are really difficult and success rates are not great. But I think there's a lot of small grants that can tie you over until you do get some success. I've probably gotten perhaps 20 competitive grants since 2018, but the large majority of them have been small, but I've submitted like more than double, triple that number. And so I think practice writing, practice storytelling, building a good team. You could do a whole session on grant writing, but like start small and when you get rejected, just try again.
Did you want to add, Shomik? No, I think that's pretty straightforward. Thank you. And I think the last question over here.
Thank you. Hi, my name is Duke. I'm currently completing my honors year as part of my biomedical science degree, and I'm also going to do a master's in nutrition and dietetics, and then I want to pursue the MD PhD pathway after that. So I'm wondering if I was to do the MD PhD pathway, would I have to redo another honors research year? Or can I just take my previous research experience from my honors?
Does anyone know that answer?
Yeah. I don't know and don't want to give you the wrong answer, but I think you'll be able to ask and find out. I mean, oftentimes for entry into a PhD program, you need to tick certain number of boxes, including perhaps doing an honours or having a publication. If you've already done an honours year, that should and may suffice. But what the specific rules are, you're better off finding out with an inquiry. I mean, these days most of that information's on the online handbook or entry requirements. And if all those fails, email someone; they'll be able to.
Okay, thank you.
Well, I think our panel has given us extraordinary insights into the complex career, but also the exciting and inspiring careers ahead. I hope you didn't just get negatives. I hope you got lots of positives. We're passionate about what we do. We spend many hours every day doing it, and we go to bed at night often thinking about how we're going to make a difference to those patients, and you really need to be a clinician-scientist to do that. You can't do it as just a scientist, and you can't do it just as a clinician. I'm going to ask the panel to stay here just while I wrap up, but please join me in thanking the panel.